Hi, everyone. Good morning. Today, we're joined by Dr. Todd Vento, Medical Director of Infectious Disease and Specialty Telehealth here at Intermountain Healthcare, to give our weekly COVID-19 update to the community. Dr. Vento, thank you so much for joining us. It's nice to see you. Of
Likewise, thanks for having me.
course. So, as always, I'd like to start with our case trends, kind of go over what's been happening in the last week. So, I'm just going to read those out really quickly. Our total cases in the state of Utah are at 376,973. Yesterday's case counts were reported at 646, which brings our 7-day rolling average to 7.9%. We've had a total of 2,015 deaths in the state, and 23 of those were reported yesterday, with 15 being reported, I do believe, before February 11th. Our total hospitalizations are at 167, which is the lowest it's been in quite some time. And our vaccines, our total vaccines that have been given out are at 936,681. People who have received just the first dose are at 618,337, and those who've received both doses are at 339,743. Let's break that down a little bit and kind of talk about those numbers. As someone who is in the hospitals pretty regularly working with these patients, I first want to ask, how are our caregivers and hospitals doing now that we've started to see this decline in cases?
Oh, it's night and day is how I would sort of describe how it felt, how it feels in the last couple of months compared to how it felt, say, November, December, and sliding into January, to the point where we've actually been able to reorganize some of our COVID efforts that used to require some concentrated tele-COVID rounds and COVID rounds for because of the number of patients on the hospital. We've since been able to pull back on that because individual providers and teams in our ICUs and the med-surg ward can actually manage those patients without having to have these special solutions to running all the cases in a different format. So I think just morale markedly increase. And I wouldn't say that everyone in the hospital feels like, hey, we're back to normal, because there's certainly always the concern that, look, we know what the virus has done, we know what the virus can do, and we also know what's happening with mutations in the virus. So very optimistic, very grateful to have fewer cases, fewer severe cases, and also fewer deaths. But knowing that we still have a lot to do to prevent us going back into those similar types of periods that we've had before with high volumes.
And can you talk a little bit about that continuing decline in cases? Do you have any concerns at all that we could see a surge? What is the data kind of telling us with this decline that's happening?
Sure. Yeah, and that's always the million-dollar question, as it were. And I know that I've even seen articles in the press of late, why folks are too afraid to be happy, or are too uh, fearful to be optimistic, and realize this tremendous optimism. I mean, the vaccines themselves for the entire world are just incredible accomplishment and have actually saved lives and are saving lives. But we are paying attention to what this RNA virus does, and we know that it mutates, and we know that it can form mutations that can actually spread more easily. And actually, if you look right now, let's look around the world. What happened in Europe then happened in New York, and then came across the United States with the original mutated strain. And right now, as of yesterday, Italy had its highest case counts with the new UK strain, that mutation or variant strain. They've had their highest case counts yesterday since November. Germany is reporting 55 to 60% of their cases are now with the UK strain. And so that's the one area where we feel that, and I'll probably get to some of your future questions, I would imagine, but it's really a race against time. It's a race to get as many people vaccinated and get as many people immune to this virus before we run the risk of one of these of the virus becoming mutated to the point where it can actually evade or escape our vaccines that we have that are currently successful, even against some of the variants.
Do you feel like Utah and even the United States has lower mutations just due to kind of where we sit? The UK doesn't really necessarily have access to us in a traditional sense. Do you feel like geography is a reason why the mutations are not happening as much in the US, or could there be other reasons for that as well?
Yeah, another great question. And the reality is, I think, there's, uh, since was first detected in the UK, then certainly there would involve time for it to spread to other locations. However, they are also doing genomic testing and looking for the variants in much higher numbers than we have and other countries have. And so I think that's probably, it's a combination of those two answers. And right now, we'll tell you, if you just look at the frequency with which we're seeing more of the UK strain, and now we even have a California strain with a specific mutation which has increased transmissibility. We're seeing higher and higher numbers of those. Houston, in that Harris County in Texas, for example, actually just reported out their concern on the percentage increase in the UK strain with that variant. So there have been a lot of responses nationally from Health and Human Services and some of our practices to account for not only that mutation or that variant, but also the California variant. There's New York variant, and again, not meant to be the picture of the baseball or softball of doom and gloom, just reality. RNA viruses mutate, and a lot of those mutations don't do anything. Some of those mutations actually improve the fitness of that virus and make it easier for that virus to bounce around in the community. So far, there's a lot of good data on the use of most of our therapeutics and also our vaccines that there should be responses. But there's also some data that makes us sort of maintain that that caution, especially with the strain in South Africa. To finish off the comment about the variants, Utah has tracked these variants as well, and we now have an increasing number of the California variant. We have the B117, which is the UK variant, and we've had just a few cases of other variants. So, this is why we don't just say, hey, we're done, we're finished, and celebrate. We have to get as many people vaccinated as we can so that we can really keep the transmission of the virus down, no circulation, and decrease the likelihood of more mutations. That's really the race, is what we're running now.
I want to talk a little bit more about the variants, specifically with the vaccines. You've kind of mentioned that a little bit, that we're learning more. Is there any specific data you think that really stands out that talks about the vaccine being effective against those variants?
Yeah, and we're learning this more and more. So a couple of things I'll mention. Well, first off, I'll say that there's already been the sort of leaning forward in the foxhole approach by the vaccine companies. So Moderna, Pfizer, as well as Johnson & Johnson, Janssen, they have already started working on other vaccines for variants. So that's underway. And that was actually something that was anticipated to begin with. That was the beauty of the mRNA platform, was that you could also switch it pretty quickly. And so those three companies have already reported that they're working on variants, vaccines that would actually be like booster effects, like we get for an annual flu shot that is a little bit different than last year's flu shot, similar concept. So that's really good news right there. There's some other good news too, in that Pfizer, and this is the steep learning curve. That's not just every week or every month, it's every hour and sometimes even more often. Like while we're talking, I'm sure there's more data coming out that we really need to look at and address. And that's why we get together with the health department, with our ID experts, public health experts, and figure out, okay, what is really going on and how do we interpret that? We work with the CDC and try to keep that communication so that we don't confuse the media, or more importantly, no offense to the media, but the public. We want the public to understand what's going on. So not to be afraid, but to know what reality is. So Pfizer has announced that it looks like right now, when they've done testing in vitro in the lab, that their serum for their vaccine actually is effective at neutralizing the variant strains. The study for J&J vaccine did show that in the individuals who were in South Africa in that study, it's like 30,000-ish vaccine recipients and placebo recipients, they had less effectiveness against that strain. Now, when they've measured those antibody responses, they are definitely lower, even 6 to 7, maybe a little bit higher, 7 times lower in terms of the amount, but still at a level that should show a lot of neutralizing effect on the virus. That said, their percent for their efficacy was lower, in the 50s, low 50s% for individuals who were in South Africa, which does reflect the presence of that strain. Fortunately, we haven't had that strain in the United States in as high numbers as the UK strain or some of our own variants, the California, the New York variant. But you can imagine if we just, hey, let's everybody travel and let's stop wearing a mask and let's just, have at it. You can see where that can go. That's where the caution comes from in our recommendations in public health.
You mentioned this term, a booster shot, and someone actually asked this question, and you said that the 3 vaccines are currently kind of working on that. Do you feel like we will be getting a booster vaccine later this year, next year? Is there any sort of known timeline on when you'd actually need that next dose of that booster vaccine?
Yeah, I would say the answer is yes. We expect that we would have to do something in the future. When that future is, we don't know yet. The studies will show how long the antibody lasts, what was the durability of the antibody for these specific vaccines based on their trials. You can imagine they finish their trials when they have, 6, 7-ish, maybe 8 months of data on the people who are in the trials. And look at this, we have 3 vaccines that enrolled 100,000 individuals between placebo and vaccine recipients. And so that data is going to be coming out regularly. We're going to know how long antibodies last in patients who are over 50 and 60 and 70. We'll have all this information that will help us to actually educate our patients. Now, there's even some data that suggests that we may even benefit from another dose of the vaccine we already had to raise the level of antibodies to protect against variants as well, without even having to change the vaccine per se, because it may be that you just need maybe a little bit higher on your neutralizing antibody titer, and so we give you a third vaccine of Moderna or a third vaccine of Pfizer. Now, none of this has been planned out or briefed by the CDC. These are the things that are being researched right now. But to answer your question bluntly, I would expect, and I think people should expect, that they'll need some sort of additional vaccine at some point in time, whether that's every year, every 2 years, or if we get a big surge of a new type of variant, we might find that we need, Moderna type 2 as our next vaccine. Those kinds of practices.
And it sounds like, too, this could be something that you said we don't know what the timeline is, but it could be something that becomes like the flu, where you get it every year, however often we figure out what that timeline is, too.
Yeah, folks should plan on that. That's what I would expect, and that's kind of what we do with circulating respiratory viruses in particular that change.
Do you have any concerns about distribution of vaccines if we do eventually need that second booster, third booster, whatever it is? Is there a concern that we're not going to have the supply when we actually need it?
I think from what we've seen, I probably get as much access to information as others do in terms of what's put out in the mainstream media, in terms of news accounts, and as well as what comes out of the White House and also from the CDC, same stuff that I think others have access to. Is it looks like now that there's so many promising activities on the vaccine production and distribution front, so much so that Governor Cox had mentioned that, hey, we're going to at least start to open it up to all ages, adults, based on vaccine criteria, age risk or age indication, April 1st. That'll be a start. That won't be like everybody gets it then. That'll be the initiation of that. And you heard the president last night, if you heard his announcement to the country, that he would like all the states to be directed to actually start making it available by 1 May for all ages of adults. And so that reflects the fact that they know that the pipeline has been increased quite a bit. Very significant interaction between J&J and Merck in terms of rival vaccine companies actually getting together to say one will use the other's production plants to make more vaccine, such that by May it's felt that we'll have doses for all Americans. And so to me, those are all very positive signs. And we're working out the kinks of how to get that into communities where it's needed, where maybe they weren't first planned for. So a lot of mobile activities to get to populations that maybe wouldn't necessarily have access to the vaccine. So a lot of those efforts, mass vaccination clinics, the use of the military, National Guard, et cetera. So I think all of those, from what I'm hearing, unless there's some other story that we're not privy to, the answer is I think the distribution part is really pretty solid and very optimistic.
I want to talk about Utah specifically. We have this April 1st date of it opening up to all adults, and then we also have the April 10th date of the statewide mask mandate ending. The first point of that I want to talk about is herd immunity. If we're getting these 1.5 million doses by April 1st, and then a week later or 10 days later, we're supposed to be opening back up, do you have any concerns about herd immunity and the lack of being below that 70% threshold?
Yeah, I think, we certainly don't, we all always said this, or at least we've said it for a long time, we have multiple tools in our toolbox. And vaccine is a tremendous thing that we didn't even have. Right 6 months ago, we didn't even know if we were going to get this, and we have it. We only have that. We have 3, and we're about to have 4, and there's actually 5 and 6 and 7 in the world. We have lots of vaccines, and so we have a couple of challenges there. One, we have still a lot of vaccine hesitancy, which is being explored in different communities to figure out what are the barriers to getting a vaccine. Is it the cultural, religious, access, mistrust in general? There's a lot of, I think, those types of concerns that were being addressed so that we can make sure that we can maximize the number of people get vaccinated. Now, we're not going to get to 90% of vaccinated, or we're still estimating about 70 to 85% as our estimated herd immunity, most of which will be vaccine induced herd immunity, because we're not sure how long natural immunity will last. But we also do have a lot of individuals who've been infected, so we'll have some of those will have natural immunity, and so that's a race. If you can see that, I already told you we're actually having increased number of California variants in the community, increased number of UK strain variants in the community, and those are more transmissible. So the more they transmit, the more they replicate, the more they mutate, the more there's a chance for a mutation that wouldn't be covered by the vaccine. Again, good news right now is that Pfizer vaccine and even Moderna has reported this, not only reported that they're covering the variants they feel, minus the South Africa. So we're really worried about that. There's some decreased efficacy there. I think that's the biggest concern, is that we all stop wearing masks, we all start gathering, we all start going to restaurants, unventilated rooms, areas, et cetera, while we're not having everyone really race to get as much vaccine and establish immunity. That's a recipe for increased cases and increase new types of virus. So I think it's really important that, it's one thing to have a legislative mandate, a legal mandate for saying, this is what we're going to do, but that's really not reflecting public health smart practices in terms of what we should still do, and also individual practices. Okay, and so that's why the CDC also tried to, and I'll sort of transition that to maybe the next question is, or the topic is that, trying to give guidance, even better and more specific guidance, to allow folks to say, look, if I do get vaccinated, I can do some things that'll be safe or relatively safe with some caveats. And that way folks can say, well, maybe I should get vaccinated if they're on the fence on getting vaccinated. So balancing a lot of concerns, but the message is the same. Get the vaccine, extremely safe, highly efficacious, some of the highest numbers we've seen in the history of using vaccines, very low side effect profile, not zero, but very low, considering that we have 100,000 individuals in studies, and now over 1450, actually multiple millions of doses throughout the country that the CDC is looking at to see what the reaction rates are in the real world. And so just, really wanted folks to realize that the vaccine is something that we absolutely should try to get into everyone who is eligible.
Really quick before we get to those guidelines, I have a question about the 3 vaccines that are currently available. You're a consumer trying to get an appointment. Should you care about which vaccine you get if you're not 16 and 17 years old? Is there any differences, or should you get the one that's available to you? Do you have any advice on how to navigate that?
Yeah, the answer, straight out up front, is to get whatever vaccine is available, because they all have a very high efficacy profile. Obviously, when folks hear the initial numbers, they go, if you just do the black and white and go, hey, 95%, wait, 70%, wait, 80, and say, well, obviously I want the one that's as closest to 100. But the reality is that all 3 of the vaccines prevent against severe infection. The vaccines aren't currently known to definitively prevent infection or prevent transmission, although there's actually data this week out of Pfizer and especially out of Israel. So Israel has a lot of data on vaccines. 50% of their population have been vaccinated, most of them with Pfizer, which is very similar to what happened early in the United States. Therefore, we have privy to some data that's coming out very quickly that's showing that Pfizer is actually now, looks like they feel there's probably about a 90% effect on decreasing transmission for asymptomatic cases. So that we didn't know before. And so as we get more experience in the real world, what we start to capture is what's called vaccine effectiveness data in the real world, whereas efficacy is in the trials. And so we hope that the 95% and the 80% translate in the real world to that, but there's so many different variables there that it's a well-controlled environment when you're doing a study, but we have to see what happens in the real world. So I will say that in particular, this data that just came out of Israel in the last couple of days is showing that the Pfizer covers a lot of the the variants very well, and that it's showing evidence of decreasing transmission. So that's very important because we haven't been able to definitively say that prior to this week. And that's why you always hear like, hey, it'll stop you from getting a severe infection, which is really important, right? You don't go into the hospital, we don't die. And obviously the most important things there. But we'd also like to be able to tell folks, hey, well, I want a vaccine that's going to make me not get infected. And so that data will come out for the other vaccines too, and we'll know that. But my advice to folks would be get the vaccine that's out there, and don't worry about differences in efficacy on numbers when they tease out more, because think about it. 15% of the population in the J&J study were South Africa, and 80% of those cases that were seen were actually the variant in South Africa, which we don't have a lot of in the United States. And so if we continue to do great mitigation measures, still do a mask, still watch your distancing, you're good at it now, right? We've been doing it for 12 months plus. We really should know that. That part we can accept, we've done it, and then get the vaccine. Then we don't have to worry about as much risk of escaping the vaccine in terms of new variants.
It's funny, I actually saw that report that you just mentioned on TikTok. So there was a doctor talking about it that came out of Israel, and I was like, oh, that's very interesting. And it was really nice to hear that there is data coming out that supports that you might not actually get COVID at all. It was very reassuring. Right. So I'm excited to see that kind of come to the US and kind of learn more about the different vaccines that are available. Certainly. So let's talk about what you can do if you're vaccinated now. So the CDC announced some new guidelines this week. I'm just going to read them off really quickly what they are. They announced if you're fully vaccinated, so Johnson & Johnson 1 shot or Pfizer 2nd shot, Moderna 1 shot after 2 weeks, I do believe is the fully vaccinated. Right. You can visit with other fully vaccinated people without wearing masks or physically distancing. You can visit with unvaccinated people from a single household who are at low risk for severe disease inside without wearing masks or physical distancing. And you can refrain from quarantining and testing following a known exposure if asymptomatic. Can you talk about what those mean for someone who maybe doesn't know everything about the vaccine? Talk to me, a person who's vaccinated. What can I do? What precautions should I be taking in those different steps?
Yeah, and I think they were clear enough. I mean, sometimes when the CDC has to balance how much detail to give to the public, in every little situation, with also wanting to make sure that they're not putting communities and populations at risk by giving that detail, but don't confuse everyone. And I think you summarized it very well. I mean, obviously, if everyone's vaccinated and you're gathering, what they're saying is you can gather in small households and everyone's vaccinated, you can take off your mask and you don't have to do 6 feet separation, act like you're all protected, and the risk of infection would be exceedingly low. I think it's important, and you described it very well, is that there's a responsibility now on the people who are not vaccinated and the people who are vaccinated to know about with whom they're interacting. So I may be thinking, oh, I'm going to go over Bob's house. He hasn't been vaccinated, but I've been vaccinated. My wife's been vaccinated. Bob hasn't vaccinated. Do I know if Bob has high risk for severe COVID? Maybe Bob doesn't know that. And so, we're not going to sit there and say, hey, before I come over, Bob, do you have the following: obesity? Are you a certain ethnicity? And I'm not trying to be silly. I'm trying to say it does put a lot of onus on the individuals who are gathering to understand that, which is not always straightforward. But certainly if you're going to go over and hang out with your grandmother or grandfather and you've been vaccinated, but they haven't, well, that would be one that I think most folks would realize, but hopefully they would have been vaccinated because they're eligible. And so, but we should be paying attention to that more. And then if you look at going out in public, you have to assume, oh, okay, well, others may not be vaccinated and they may be at risk. And that's kind of the same as saying, I'm going over to someone's house, I'm vaccinated, but they're not vaccinated, but they have a high risk situation. And therefore I need to wear a mask and keep distance. Same thing in public. And I think the big takeaway would be this: vaccination is for my safety, but it's for our safety and it's for other safety, just like masks were once we got that correct guidance down. All right, it's not just about me, it's what I do, and that's also going to help others. And that's really what it's all about. We're in the same boat. We've been in the same boat, and we all want to row right to the same shore. And this is where we have to still be very meticulous about how we gather. Just don't, throw off the mask and burn them and act like, everyone's protected. We need to get more people vaccinated. And I think everyone still needs to pay attention to these guidance. I will commend the CDC for going out, not on a limb, but for being very specific about, well, you could do this, you could do this. And truthfully, they don't hide it. They also feel that, well, that will also incentivize folks. Because, some people think like, if I'm gonna get the vaccine, but I still have to wear this mask and I still have to distance, why do I get the vaccine? Of course, get it because it could save your life. It has a 95% chance of stopping you from having a severe symptomatic COVID infection. So, yeah.
I think another thing around that too is we talked about how the statewide mask mandate is ending on April 10th, but you've talked about this personal onus, this personal responsibility. If you still want to wear a mask and you still are more comfortable wearing a mask, especially in public, I don't think people should not do that. And I think that's important for if you go to a store and their rules are wear a mask, to be respectful and make sure you're actually following those guidelines, because like you said, you don't know someone's personal health history. They might not be vaccinated and they might be very high risk. So is there any other advice for people going out in public after that April 10th timeline of kind of what they should be doing going forward?
Yeah, honestly, I would say there's no difference between April 9th and April 10th. It's a random date. I know there were other stipulations that were put out, like 191 per 100,000 incident cases and a percentage of individuals who were vaccinated, which is actually good to actually look at that and say, okay, what we're really getting at here is, and I know it's, we all want the black and white answer. Is it the economy? Is it the virus? Is it you're vaccinated? You're not? And the answer is, this is gray. This is the real world. This vaccine or this virus rather, has changed so much and has taught us, unfortunately, at the expense of individuals and becoming sick and dying and being hospitalized because it's a brand new virus and we're still learning about it. So I would say I wouldn't look at April 10th as anything different from my own personal protection and for others' personal protection, and say that you should continue to say, if I'm out in public, I should probably be careful if I'm going to go in a place that has 100% occupancy now, and I don't know about their ventilation system, and people aren't wearing masks, because we don't have a large portion of our population vaccinated, and they're still at risk, even though we have lower cases and less virus than we say had in the, after Thanksgiving, after Christmas. The reality is we still have virus. We still have 500 plus 7-day rolling average, and we still have, depending on which stats you use, 4 or 8%, person over person or test over test on our test positivity. And those were numbers that we had when we had been on lockdown. So I know we've changed a lot, like we've accepted a lot more tolerance because folks want to get back to work and want to have normal. The reality that's in front of us is the reality we have to address, not the reality we want it to be. We have to work towards that reality. And so I would still encourage folks to continue to take these precautions until we really had, if you tell me in July that we have 85% of Utahns vaccinated, I would say you're probably a lot safer not being as masked, not, avoiding, say, restaurants, et cetera. But those things will increase the risk of exposure before we get to a level of more diffuse immunity in the population.
My last question for you is kind of around that timeline. There's been talks from our governor and the federal government about this July 4th timeline of opening back up and being 100% back to whatever your normal was previously. Does that feel like a realistic timeline? Is it too early to tell? Should we be telling people a realistic timeline of when normal can go back to that?
I listened to the president's message last night, and I thought he said it in a way to sort of put a point of hope out there, something to shoot for, but also caveated that with, hey, we're not out of it yet. We're still building the tunnel to get to the light, kind of thing. And we're still in that process, so we can't quit. And I think he put enough caution there. I think that's different than saying like, oh, we will on 4th of July, burn our mask and start getting together. I think the caution that you're hearing on the variants, and people are tired of hearing about what this virus is doing now, but guess what? That's what the virus is doing now. And I don't want to hear it. The virus is a nemesis. It's a enemy for us. I think, the analogy that I would say is that if you're in a combat against an enemy and you just feel like you had a great victory, would you the 1 hour later throw away all your weapons and feel like, oh, we're in the clear, we don't have to do anything, we can throw away all our weapons? And now you have another enemy that shows up and another enemy shows up, and you really wish you would have kept your weapons. And so apologize for the ex-army retired analogy, but I think it's relevant that we have tools in our arsenal, and we need to still use them all, because that'll make it so that things like a July gathering with a high level of community immunity will be possible and feasible. Now, what has to go into that is we need a lot of folks really supporting mass vaccinations and the continued pipeline. And I think, the Department of Health and Governor have really emphasized that. And I think if we have that, we can get there in the summer. And that's really what we're all shooting for. And I think that's what the president was really trying to say last night. Like, hey, that's what we want. That's what we're going for. But we still got work to do.
I hope no one burns their masks.
Yeah.
Keep them as souvenirs for when you look back at this time from 10 years.
Yeah, those weren't my words. Those were someone else's words who runs the state. But
and it's probably bad for the environment too.
Yeah, there you go. Very, very well put. We have air quality issues too that we'll need to continue to address.
Dr. Vento, is there anything else you'd like to mention before we sign off for the day?
Yeah, I think I would say I know we run the risk of sounding like the Debbie Downers or the doom and gloom folks, but there's a lot of positive data that's coming out. And even, like I said, I mentioned this week, and even the confusion over whether 1 dose or 2 doses was good, even out of the Israel data that they show a doubling of the antibody response with the 2nd dose. So that was helpful too, to put people's, to give us really hard evidence in a real life situation that, hey, getting that 2nd dose and not just giving 1 and seeing what happens, that's important. And also that this 90% decrease in risk of asymptomatic transmission was big. Now, that's their population. That may be a little bit different than ours, but I think the reality is those are really hopeful signs and findings. So even more reason that we have great tools that work, and we've had this miracle of developing multiple vaccines for the world. We really need to use them now, right? The old adage is that, vaccines really don't do anything. It's vaccinations that actually stop the public health emergency.
I think that's a great last line, and I think that's great advice for people. And if anyone watching wants to find out where they can get a vaccine, they can go to intermountain.com/COVID vaccine. We have a list of Utah, Nevada, and Idaho eligibility and where you can schedule. There's our resources you can access, but also others throughout the state of Utah. We also still are doing testing. And if you're interested in testing for COVID-19 specifically, you can go to intermountain.com/COVID testing. We also have our emotional health relief line available 7 days a week still from 10 a.m. to 10 p.m. It's a free resource to the community in case you need some extra support. That phone number is 833-442-2211. Dr. Vento, thank you so much for joining us and giving us all this great insight, and we'll talk to you later.